Today's topic for discussion is endometriosis. Next. So, endometriosis is a chronic gynecological disorder characterized by the presence of endometrial like tissue outside of uterus and is associated with pelvic pain and infertility. Usually located in the pelvis, but it can appear anywhere in the body. And the common sites of endometriosis are ovary, anterior cul-de-sac, uterosacral ligaments, broad ligaments, fallopian tubes, sigmoid colon, and appendix. There are three main types of endometriosis. They are peritoneal, deep infiltrating, and ovarian endometriosis. Basically, this is an estrogen dependent disorder, and apart from causing pain and infertility, it has adverse effects on quality of life, not only of the individuals, but also of the couples. Next. The incidence of endometriosis has been shown to be 10% in reproductive age women, and it is 60% in those with chronic pelvic pain. And because of the diverse spectrum of symptoms and signs, the diagnosis is often delayed, and the mean age of diagnosis is around 25 to 35 years. Coming to the pathogenesis of endometriosis, Samson's retrograde menstruation, which explains the incidence of endometriosis in most of the cases with obstructive type of Mullerian anomalies. And coming to the next theory, which is Ferguson coelomic metaplasia, which explains the occurrence of endometriosis in peritoneal cavity, pleural cavity, urinary, and gastrointestinal systems. Vascular and lymphatic dissemination of endometrial cells, direct transplantation of endometrial tissue. These explain the occurrence of endometriosis at distant sites, including the cranial cavity. Immunological factors like cellular factors, which include the macrophages and NK cells, and humoral factors, which include the interleukin 1, 6, 8, tumor necrosis factor, vascular endothelial growth factor, and RANTES, have been proposed to be the causes for immunological side of endometriosis. Genetic factors and epigenetic changes have also been implicated in pathogenesis of endometriosis. Coming to the molecular mechanisms, the endometrium, which is eutopic and ectopic endometrium of endometriosis, it behaves differently from a normal endometrium in three ways. Mainly, it produces high local estrogen, it produces high local prostaglandins, and it is resistant to the actions of progesterone. Coming to the symptoms of endometriosis, which include dysmenorrhea, which is the most common symptom which is seen, and particularly when it is having a new onset, severe enough, and it is progressive, it should give us a hint of endometriosis. Dyspareunia is the next common symptom, and non-menstrual pelvic pain, which is nothing but the chronic pelvic pain, is also a most common type of presentation. Apart from that, other rectal and urinary symptoms like dysgeusia and cyclical urinary and bowel symptoms and infertility, along with chronic fatigue, have been implicated as symptoms of endometriosis. And the severity of symptoms doesn't correlate with the severity of disease. And this is the reason, because of the diverse nature of the symptoms seen in endometriosis, the diagnosis is often delayed because these symptoms are often neglected or as thought to be due to other causes. And treatment may be initiated based on clinical diagnosis itself. Pain. So coming to the causes of pain. Pain is caused due to direct and indirect effects of focal bleeding from the endometriotic implants, inflammatory cytokines in the peritoneal cavity, irritation or direct infiltration of the nerves caused by the uh, deposits of endometrial implants, and it has no correlation with the severity of disease. Sometimes, in cases of minimal to mild endometriosis, we see severe pain. On the contrary, in cases of moderate to severe endometriosis, the pain symptoms might be very minimal. So the severity of pain doesn't correlate with the severity of disease. Infertility is one of the next alarming presentation of endometriosis, wherein it is seen in 30 to 50% of the women with endometriosis. And various factors like mechanical factors, inflammatory factors, cell signaling, epigenetic factors have been implicated to be the causes of infertility. What not coming from the oocyte quality to the tubal factor to the endometrium, including the cervix and the vaginal causes, can be implicated to be the causes of infertility in endometriosis. Coming to physical examination, speculum examination, you may note bluish or red deposit in the vaginal fornices or the cervix, which may bleed on touch. The uterus may be retroverted with decreased mobility or complete fixity. Sometimes you may feel tender fixed adnexal mass in the lateral fornices, which could be due to endometrioma of the ovary. Sometimes tender indurated nodules may be felt in the uterosacrals or in the rectovaginal septum, which concludes the diagnosis of deep infiltrating endometriosis. Physical examination is always inferior to surgical diagnosis, and endometriosis should not be ruled out based on any negative physical findings. Non-invasive testing CA125 doesn't have much role because it is elevated in other conditions like pregnancy, acute PID, also in the cases of fibroid, wherein the levels have not been shown to be correlating with the diagnosis of endometriosis. Circulating microRNAs has been proposed as a recent modality of non-invasive testing, which is still in the research phase because the activity of microRNAs is found to be different in those with endometriosis and those without the disease. Coming to imaging, transvaginal sonography and MRI. So TVS is the initial imaging modality to diagnose ovarian endometrioma, but it doesn't give any information about the adhesions or minimal peritoneal deposits. If the TVS is inconclusive of any adnexal ovarian mass, then MRI can be done in such cases to confirm a diagnosis of ovarian endometrioma, but neither of them can rule out other forms of endometriosis apart from ovarian endometrioma. Coming to the surgical diagnosis, laparoscopy with histological examination is considered to be the gold standard. Histological examination is preferred but not required to establish the diagnosis with reasonable certainty. If the laparoscopy findings are consistent, laparoscopy should be considered as a therapeutic option rather than for diagnosis. Coming to the classification and staging systems, the staging system in endometriosis is purely surgical. So in 1979, there was an AFS classification, which was revised in 1985 and 1996. The revised ASRM classification has come up. In 2005, there was an Enzian system of classification for staging of endometriosis. In 2009 came the Endometriosis Fertility Index score, and 2017 the World Endometriosis Society has come up with a classification system toolbox and included the revised ASRM, Enzian, and EFI system of classification. So this is the revised ASRM classification for endometriosis. And in this, the disease is staged surgically, either by laparoscopy or when the situation demands on a laparotomy due to other condition. So here the disease is staged into 4 stages: minimal, mild, moderate, and severe based on the scoring, wherein the cumulative score of 1 to 5 is considered to be minimal, 6 to 15 mild, 16 to 40 moderate, and more than 40 is considered to be severe endometriosis. Next comes the endometriosis fertility index surgical score. In this classification, a least function score is given at the conclusion of surgery, and based on the factors which include the historical factors and the surgical factors, a cumulative score is given, and based on the score, the percentage chances of pregnancy are predicted in this score. And this provides an edge for this endometriosis fertility index score over the other classification system, wherein the predictive chances of pregnancy have not been commented. Coming to the treatment part, so the management of endometriosis is divided based on what purpose the treatment is focused on, whether that is for pain or infertility, because both paths are completely different. And in the management of infertility, the management of pain components should not be mixed. So, for the management of infertility, coming to endometriosis, we should take into account various factors. The major factor is the age, severity of disease, presence of other infertility factors, ovarian reserve, presence of pain symptoms, and EFI score. Indications for surgical management are pain and inaccessibility of the follicles in case ART is planned for that patient. Apart from that, there is no surgical indication for management of endometriosis. There is a controversy wherein the ovarian endometriomas more than 4 centimeters have to be guided for surgical management. This is a disputable topic, and decision has to be individualized based on the couple's history and examination findings, ruling out other infertility factors. And increased risk of first trimester miscarriage and ectopic pregnancy have to be taken into account when planning pregnancy. So, coming to the management of endometriosis, in stage 1 and stage 2 endometriosis, if the age is less than 35 years, then if you need to individualize whether the treatment is for pain or infertility. If it is for infertility, then the couple should be given options based on overall fertility evaluation. If everything is normal, like the semen analysis and the tubes are patent, age is less than 35, ovarian reserve is good, then ovarian stimulation with IUI can be given as an option. If the couple are not willing, then expectant management can be tried for a couple of 3 to 6 cycles. And if it doesn't respond, then it has to be upgraded to ovarian stimulation with IUI. If this fails, maximum we can try up to 3 to 4 cycles of ovarian stimulation with IUI. And if this fails, the next step of management will be IVF. On the contrary, if the woman is already more than 35 years, then we have to counsel the woman regarding the chances of pregnancy and increased risk of oocyte aneuploidies beyond 35 years of age. And we should give an option of ovarian stimulation with IUI. And in case if it fails, then directly to IVF. But in cases where the ovarian reserve is very low, option of IVF can be given directly. And again, I'm telling you, the case has to be individualized, taking into account all the fertility evaluation parameters, including the male factor, the ovarian reserve, tubal patency status, and all. So, extensive ovarian endometriosis with low AMH, option of fertility preservation has and has to be reinforced. Operative intervention for endometriosis has to be planned in a multidisciplinary surgical team in the event of incidental deep infiltrating endometriosis, which could be diagnosed at the laparoscopy. And ovarian reserve reduction must be taken into account, and patient should be counseled regarding the same in case there is ovarian endometrioma and you are planning for excision of that. Surgical management should ensure complete excision of the deposits with adhesiolysis and tubal patency evaluation to restore normal anatomical relation as much as possible. because incomplete resection of the deposits will result in an early recurrence, and it will be of no point to the patient either in terms of pain or in terms of fertility. And the probability of recurrence after laparoscopy has been found to be 40 to 45% at 5-year follow-up and 20 to 25% at 2 years follow-up. So IVF. Coming to IVF, when it is suggested as a treatment option in endometriosis, in moderate to severe endometriosis with diminished ovarian reserve, we can give an option of IVF directly, especially in those women more than 35 years of age, and when it is associated with tubal or male factor infertility, and also in cases with minimal to mild endometriosis with failed IUI cycles. So maximum we can try up to 3 to 4 cycles of IUI, and if it doesn't respond, then the next option will be IVF. And also in those with advanced age. So antagonist versus agonist protocol, which is better for endometriosis? Both the pregnancy rates and live birth rates have been shown to be similar both for antagonist and agonist regimens in controlled ovarian stimulation for endometriosis. So either of them can be chosen as a modality for controlled ovarian stimulation. And in cases of endometrioma, when you are planning IVF, prophylactic antibiotic cover at the time of oocyte retrieval should be given to avoid secondary infection. Coming to the treatment of pain, which includes medical modalities like NSAIDs, combined oral contraceptives, GnRH analogs, progesterones, danazol have been tried, and selective estrogen receptor modulator, progesterone receptor modulator have been in research phase, and immunological conjugates have also been in research phase. This has to be individualized. Management of pain has to be individualized, considering the age, desire for pregnancy, severity of the symptoms, extent of the disease, side effects, and costs of the medication involved. Surgical treatment for pain objectives are to restore the normal anatomical relationship, remove all the visible and deep disease to the extent possible, and prevent adhesions. To prevent adhesions, barrier devices can be used, but there is no evidence supporting the use that they will prevent adhesions. Post-operative hormone suppression therapy is recommended for 3 to 6 months to minimize the risk of recurrence of pain, but it is not indicated in those who are planning immediate fertility. So, the management of endometriosis has to be weighed and balanced, taking into account the couple's factors. So, initially evaluating the couple, taking into factor the age of the female partner, the semen analysis parameters, tubal patency status, severity of endometriosis, and the decision has to be taken taking into account all these factors. So it has to be individualized for the couple, and the only indications for surgical management are pain, or in case the ART is planned, if you feel that the ovarian endometrioma might block the retrieval of the oocytes. In such cases, you can plan for surgical management. And in endometriosis, more than 4 ovarian endometrioma more than 4 centimeter, the evidence is controversial. Some studies say it has to be managed surgically and then plan for ART based on the reserve. But before going for any surgery for ovarian endometrioma, evaluate the AMH first, and after the surgery you need to reassess the AMH, and before surgery you need to counsel the patient that there might be a decline in the ovarian reserve and it has to be aggressively managed. Thank you. Any doubts?